Brady Bunch screen here. But I am Jorge Sanchez. I am the Program Director of Diversity and Inclusion at 4Health Consulting and member of the Diversity and Inclusion Office. I have the distinguished honor of sort of being the co-chair and co-lead along with Dr. Jules Troba in terms of the Centering the Margin series, which is really developed by our Vice Chancellor, Dr. Marlena Duncan. And we just wanted to welcome you again to today's session titled The History of Racism in Healthcare and Its Effect on Indigenous Health. And it will be a panel discussion. We'll have the opportunity to hear from, again, some of our esteemed partners and colleagues from the Hassanimisco Band and others. So we are very excited to have a large number of response here. You will have the opportunity, please. We want to make this as interactive as possible to use the chat feature. Jules and I will be manning the chat room. Please feel free to insert any questions throughout the course of the conversation. So, as we continuously bring our larger UMass Chan and community members together, it's often an opportune time to reiterate that UMass Chan Medical School acknowledged that its campus is located on lands that were once part of the original homeland of the Nipmuc people. We denounce the violence that stripped these original stewards of lands that were their ancestral home and denied their descendants the opportunity for an authentic connection to it. In making this acknowledgement, we announced our intention to listen to and follow the lead of our Indigenous neighbors and work together to create new legacies of equity and respect. So thank you all for joining us again. For those of you for the first time joining us, to give just a brief overview of the Centering the Margin series, this was a speaker series that was really designed to lift the voices and stories of diverse communities that have been traditionally marginalized, an opportunity to center conversations and stories and really put together to spark inquiry and innovation in the DEI space and really challenge ourselves to think about and learn from one another, create and discuss bonds and celebrate the unique needs of our diverse communities that we serve and impacted marginalized groups. So we're very excited that we're going to be bringing this conversation to the fore today. This year, our theme is racism in healthcare, realizing that racism in healthcare has been very well documented in the form of racial disparities. And we want to really take a systemic approach to these conversations. So as we prepare these conversations and speakers, and we really charge each of us around the room here to really think from a systems framework. So as we hear stories and data, that we really think about how historically marginalized individuals encounter healthcare and educational systems differently. What does that really look like and mean for the individuals and these systems? And ultimately, how can we get to conversations today on how do we look to find ways to dismantle the oppression in these systems? So we're very excited to have some of our key partners in the community. And I'm going to turn it over to Dr. Jules Troba for introductions.
Thank you. So today it's our pleasure to introduce to you Dr. Lundy Brown, who is a scholar from Brown University. And each of these speakers will have about 10 minutes to discuss their work and how it relates to the topic at hand. And then we have Chief Cheryl Holly. She's the chief of the Hassanimisco Band. And then we have Nurse Nicole Kazarian, who works in the Worcester Public Schools, but is also a Hassanimisco Band member. She's having a little trouble accessing, so she may be joining us a little bit late. So without further ado, I'm sorry? Oh, you made it. Wonderful, wonderful. Thank you, thank you, thank you. Thank you for speaking up. Okay, so wonderful. So now why don't we go to Dr. Lundy? Dr. Brown, sorry.
No problem. Well, first of all, I would like to apologize a little bit for my appearance because I took a big fall on a hiking trail. So it's all bruised, but I'm not in any kind of pain and I'm very, very happy to be here and to join in welcoming all of you. And I so look forward to the discussion in the Q&A. I want to thank, before moving on to my brief remarks, I want to thank Dr. Jules Troba and Lynn Hernandez, both for the invitation to be here today. I'm so very grateful, and I'm especially grateful to appear with my fellow panelists, Chief Holly and Nurse Kassarian. So racism has a long, persistent, and deeply, deeply pernicious history in the US and globally that we all understand, of course. And that, it works in multiple ways. And I'm going to just try to get an angle into some of the more subtle ways in which racism works in our society, and particularly in medicine. Why, I ask, did it take the murder of George Floyd into 2020 for some recognition of the issue to take place, when there had been police murders extensively in our country, really since it's the earliest years of the Republic? In the wake of Floyd's murder, many are only now learning about the subtle and invisible ways in which racism permeates our society, and especially permeates medicine. And medical algorithms, something that may be familiar to many of you. They've been in the press over the last couple of years quite a bit, but they're one such example of where we don't even really look for racism. Slide, please. So much has been written about medical racism, a lot. This is just a small sample, and there's many new books out. Linda Villarosa's Under the Skin is quite a nice overview of racism in medicine. But I would like to start with W.E.B. Du Bois, a very important and famed Black scholar who, from the late 19th and early 20th century, wrote insightful texts that have not yet been surpassed. I mean, if you read The Philadelphia Negro, you will be blown away by how contemporary it actually appears. His work are truly remarkable efforts to change society and to change medicine. So this is back in the late 19th century and early 20th century. Most recently, I would like to point out Harriet Washington's quite comprehensive case studies on medical apartheid, about medical racism, which is useful for anybody who hasn't. It's not a book you can sit down and just read through, but it's a really fantastic series of case studies. So why are we we only finding out about this history now, when many have been writing about it for centuries? There have been all sorts of apologies in the wake of Floyd's murder from numerous departments in medicine. If you're in the Department of Medicine, you've probably heard some of these apologies. But one question I would like to pose is, to what extent will the horrors of racism change because of these apologies? To what extent do they really go to the core of how racism has been produced? I would also like to point out that despite this broad literature, there has been very little dialogue between biomedical sciences and the humanities and social sciences, of whom scholars are writing these books. So that's unfortunate, and we could think of how that could change. Next slide, please. Next, yeah, great, thanks. This slide illustrates some of the areas in medicine in which both explicit and implicit racism operate. And what I would like to point out, despite many of the workshops that imply that there's a separate space for implicit racism, a separate space for explicit racism, that they are inseparable. And I'm not going to go into that point, but I think if you look at the slide, I make some attempt to have the arrows going back and forth. I'm not a very good artist at all, but I do want to make the point that what happens in the space of health disparities, research, for example, is deeply intertwined with that of healthcare, the lived experience of the clinic for patients, for students, for providers, for staff. And what I'm focusing on right now in the discussion of medical algorithms is knowledge production. And that quite simply is, what kinds of studies do we do to learn more about health and disease, and to what extent is racism built into those studies? And then we publish those studies and teach them to medical students, whether in lectures, in board exams, in Q banks, in textbooks, except although there's not textbooks so much anymore, but biomedical journals and training. So the big circle is the area that I'm focusing on. Next slide, please. So this is a picture of two different spirometers, and the spirometer measures lung capacity. If you have any kind of lung condition, you may have had your lung capacity measured. You may or may not have known when your lung capacity was being measured that there's this long history of the idea that there are racial differences in lung capacity, and those racial differences are innate, that we are born, racial groups are born with those racial differences. And that gets enacted in medicine as race correction. So race correction can either be through a factor of 10 to 15% or using different population-specific standards. The point here is that race correction places pulmonary function tests in a hierarchical order. And this hierarchical order dates back centuries. So there are two more points one more point I want to make is that with the spirometer on my left, there are two buttons. One says race and one says sex. You cannot make this machine work without pressing that button. So the operator has to press a race button. And into that, they enter into a world of racism. On the right, there's a pull-down menu. It's a more sophisticated spirometer. And I saw this in South Africa with a pull-down menu, and they use the language of white or Caucasian, which I just want to point out is a seriously scientifically racist term that dates to the late 18th century. And two other options in the pull-down menu are African and Mexican. Both come from standards in the US for African American and Mexican. And there's reasons for these differences, but they're quite significant, and they tell you that in the spirometers worldwide, it's kind of a mishmash of standards. When I first wrote my book on race correction of pulmonary function tests, and even now, many are quite quite surprised that the spirometer number 1 has a history. Beyond that of its technical development, a sort of great white men history, and sometimes great white women history. And we're familiar with all those histories. But secondly, people are quite surprised that this history is bound up from its earliest years of the development of this medical device with race. And that thirdly, this early racialization continues to the present as race-based prediction equations that involve reducing normal in groups other than white people by a scaling factor. I think this will change, but it's taking a long time to do so. So next slide, please. This is an important and engaging time to be discussing race correction of pulmonary function tests. I was on a working group of the American Thoracic Society, which just published this report that reflects the tensions in pulmonary medicine, and it includes a section on history. And that is only because of the leadership of the first author, Nirav Bhakta. It's almost unheard of to have history built into a biomedical report. And I think it gives us a different sense of how biomedicine evolves. Medical algorithms have been an important feature. Next slide, please. An important feature of this discussion about racism in medicine over the past few years. In 2019, members of Congress, notably Cory Booker, Elizabeth Warren, Barbara Lee, and Ron Wyden, took note of what was being published in the scientific literature. And there's one really significant paper in the New England Journal of Medicine, and they raised questions among themselves first and then publicly about why are we using race-based algorithms? And they issued this report in 2021. It's on the internet. You can look at it. I don't agree with everything, but it's an excellent report and well worth getting a sense of the range of medical algorithms in medicine. They permeate medicine, from cardiology to obstetrics and gynecology to nephrology to pulmonology and so on. So it's an important way to see how subtle racism can be, and it's subtle and invisible. Next slide, please. So let me return just very briefly in conclusion to discuss a little bit of the significance of history to understanding biomedicine and racism in particular. In 1995, Michel Roth-Trouillot wrote a wonderful short history of Haiti entitled Silencing the Past, where he argued that we are never so steeped in the past as when we pretend not to be. This is, of course, ever so true in the case of race correction of pulmonary function tests. Every time we press those buttons use the pull down menu, we're steeped in a history of racism. And in a sense, we're a participant in the racism. So where did this idea come from? And was there dissent? Next slide, please. Unfortunately, there was more dissent in the 19th century than in the 20th century. And that tells us about how ideas get hardened and very difficult to dislodge. Next slide, please. I began tracing the idea. You can't really read this, but the point is I published an article about race correction in 2005. So at least since 2005, we've known something about race correction and pulmonary function tests, which we've kind of ignored. I began tracing the idea in the scientific literature and the historical literature, and it took me about 20 years to write my book. I was very meticulous, and I wasn't a pulmonologist, so I had to be very careful. As it turned out, next slide, please. That idea of racial difference in lung capacity dates to Thomas Jefferson, the third president of the United States, that you may or may not know. But what's more important here is that he was a highly influential Enlightenment thinker. Jefferson was the first to suggest in his famous late 18th century notes on the state of Virginia, a vicious racist diatribe that enslaved Black people differed in the very structure of the pulmonary apparatus. In Jefferson's hands, the pulmonary apparatus was deserving of attention, but it was one defining characteristic of enslaved people that struck to the heart of their humanity. And this is about humanity at its very core, making them unfit for freedom and citizenship. Fitness for agricultural labor of enslaved peoples is a persistent theme in this literature. Jefferson's work was picked up by future scientists, first Samuel Cartwright, and then many scientists that look very, very normal to all of us. And I want to just end by saying that the ideas of difference were innate, persisted to the present, and they did not get dislodged. They rarely got questioned. So there was questioning in the 19th century, mostly by Black scholars, and then one questioning in the 20th century by South African epidemiologists, Johnny Myers and Neil White. But none of those really wonderful works got picked up in the US literature. They were fundamentally ignored. So there was very little critique, and until recently in the 20th century, no critique. Next slide. I think that's the end. So this slide just illustrates for you the hierarchy that's embedded in pulmonary function tests and in race correction. What really, I was going against pulmonary medicine, and really that's kind of challenging to do. And but what just stuck with me throughout these 20 years was that any scientific measurement where white people are at the top and innate genetic difference is a frequent explanation for what is framed as deficiency should give us all pause. And thank you very much.
Thank you so much. So now we'll turn the panel discussion over to Chief Cheryl Tony Holly. And I just wanted to keep everybody in the loop and say that, if you have questions or anything like that, put them in the chat and we'll have time for a discussion at the end. Thank you.
Thank you, everyone. My name is Cheryl Tony Holly, and I am the Sunsquaw, or female leader of the Hassanamisko Nipmuc Band, which is one of 2 state-recognized tribes here in Massachusetts, Nipmuc tribes, Hassanamisko and Chibunagungumag. So listening to Dr. Braun's presentation just reminds me that racism in medicine really has its roots in the fact that, Black people are only considered 2/5 of an actual human, and Indigenous folks are still housed under the Department of Interior in our federal government with Fish and Wildlife and national parks, so that racism stems from the fact that you just don't really think we're human or human enough. And that's, making me a little ticked off right now, but anyway, on with the show. My part in this panel is to give you a little bit of history about Nipmuc people, who we are today, and what we're doing for ourselves in terms of improving our health. So the title of my presentation is Natiyamwan Masketu Nuachi Ninawan, which means we make medicine for us. And next slide, Jules. So a little Nipmuc history. This is a map, and the map's, not at all accurate, showing our traditional homelands, but this one is pretty good. You see Nipmuc smack dab there in the middle of Massachusetts, a little bit of Connecticut and Rhode Island as well. We still consider those our homelands, a little bit closer to Connecticut River, but we still consider this our homeland. We've been here for anywhere from 12 to 15,000 years at least, judging on artifacts and remains that have been found. We kept our history orally before the Europeans arrived, so we don't really have written records from that time back. You can go to the next slide, please. Wards of the states. So we've been wards of the states or wards of the colony since the English arrived. So back in the 1600s, when the English came, our reaction was to share. I mean, they came saying that they were tossed out of their homelands, and they needed a place to live. And of course, being colloquial when I was saying this stuff, but and so we shared our land, we shared our resources, we did all of those things, and it took us a while to realize that we weren't on the same page. That the Europeans had a different goal in mind. They didn't want to share. They wanted to have those resources for themselves. So in the mid 1600s, Nipmucs, along with other tribes, were put into these things called praying plantations, mostly in our homelands. But people there, if you wanted the protection of a praying plantation, you had to act like the English. You had to drop some of your culture and some of your customs, dress like the English, use English names, things like that. And eventually, many of the tribes here in central New England understood that the English were not here to share or help or anything. And then what happened as a result of that understanding was King Philip's War, which the Native people lost badly. And we never recovered from that. And after that, we became wards of the colony and then wards of the state. And as wards, we are not allowed to control our own lives at all. The lands that we lived on could only be sold or leased or rented if we had permission from the colony or from the state. We had trustees or guardians, they called them, to make sure that we did what we were told and stayed in our lane. They controlled whether land was sold or bought or rented. They controlled monies that we received from sales. They controlled how we made our lives. They controlled our children, sending our children into English homes to be indentured and raised outside of our culture. They controlled how we spoke our language. They controlled how we dressed. And that went on until, next slide, about 1869. When, after several government studies, they decided that, hey, we might as well give them citizenship. That would be better for them. Turns out that when citizenship came, the state took that as we don't need our homelands anymore, and they sold all our communal lands. Thankfully for us, we still had one piece of land left in Hassanemisco, what is now the town of Grafton. And I think you can hit next slide and a picture will pop up, but nope. All right. So Grafton or Hassanemisset, that is where the Hassanemisco band is centered now. We have been actively pursuing our lives, trying to reclaim things like our language, our customs, our culture, our arts, our crafts, and most importantly, our health. So, I don't have any scientific studies to show how racist medicine really is in America, or in the world actually. But I can tell you how people feel. We know that when we go to the doctors, they dismiss what we say, or they don't think it's important, or they over medicate, or they under medicate. We know that when we take our children to the emergency room, if they fall and hurt themselves, that's an invitation to have the state come to our home to investigate us for neglect. We know how we feel when we're treated differently or not as well as others. I was a nurse for more than 30 years, in the UMass system even. And I mean, I can see, I can hear my colleagues say things or treat certain patients differently all the time. I mean, it's just embedded in our lives. So what we decided to do, we have a long history of type 2 diabetes in our community, a long history of heart disease in our community. But about 12 years ago or so, maybe longer now, some of our teenagers developed type 1 diabetes, which was very alarming for us. Totally out of our wheelhouse. We had no history with that at all. So we began to look at what we were doing and how we could help ourselves. One of those teens actually died later because he couldn't afford his insulin. That was during that I think it was maybe just before the pandemic, around that time, where insulin prices shot up and people couldn't afford it. He happened to be living in a state where they didn't have the same kind of healthcare we have in Massachusetts. And he was 29 years old, and he died because he could not afford the kind of insulin that worked best for him. And we don't want that to happen to our people. So we started figuring out ways to help our folks. We did try to partner a couple of times with some professors at UMass Medical School to do some research, and that never really panned out. So we took it upon ourselves. We understand that diabetes and heart disease both are dependent upon what we eat. And so we started growing our own food. We started in gardens. We started teaching people how to garden in their own homes, how to put up raised beds, how to do patio gardens, things like that. And then the women's group started growing food on the reservation to freely distribute to our people. We started enacting policies like no soda, distributing clean meat. We have an agreement with an organization called the Farm School, who was also going to give us a farm of our own to distribute that meat for free to our community. And next slide. Finally, in 2017, we did a Nipmuc tribal food assessment. This is our second actual health survey of Nipmuc people. The first one was in, I think, 1998 by the Nipmuc Women's Health Coalition. And that was the first survey of Indigenous health throughout the whole state of Massachusetts. And we found many things that we found wrong. And mostly it was the idea that people did not want to go to the doctors because of the way they were being treated. And so the Nipmuc Women's Health Coalition set up clinics and places that were favorable or that would treat people well. And that's how people got our healthcare back then. This point here, we didn't have the Nipmuc Women's Health Coalition anymore. So we had fallen back into that, not really wanting to go in the doctors and waiting until it was too late and going to the ER. So we decided to take these matters into our own hands. So Wananamuak Nuachi Nisiminuak means we want good health for all our people. And so we had our youth take these assessments and assess their family members, their cousins, their aunts, their grandparents. And we came up, I think if you hit next slide, there might be a picture popping up. Hopefully, yep. So one of the things we found with heart disease and diabetes, we focused on those two because we knew those were prevalent in our community. And in families, 51% of all the people surveyed said that both diseases were in their family, which we thought was excessive. So then our plan now is to expand our farming, expand our food growth, and make sure that our people can afford clean food for their health. Another way that we're doing those is by teaching our women and our men how to use plant medicines. Next slide. So Musketu means medicine. And this is a picture of Nia Hawley. She's one of our herbalists. We have 3 Nipmuc apothecaries at this time that distribute medications or plant medicines for free to our people and to other people. There are plenty of people at Hanneman who I used to work who have benefited from our apothecaries. So we do this because we want to make sure that our people have chemical-free, safe medicines that they can take. We don't just hand out herbs for people. We talk to them, we find out what's going on, not just what their symptoms are, but why they may have those symptoms, and treat that itself. We make sure that none of the herbs that we give out interact with the medications that they're on from their doctor. So we're very careful about that. The next slide. These are more pictures from one of our herbalists, Nia Hawley. Yeah, so I guess it's what we're doing. We're trying to, well, we can't really counteract the racism that goes on in doctors' offices and at pharmacies and laboratories and things like that. We can do what we can for our own people as best that we can. And we're hoping that we have a better relationship with medical staff and medical people. This is why we want to enter into this relationship with UMass Memorial Medical School, or UMass Chan, I'm sorry, Medical School, because we want the next generations of healthcare workers, whether they're nurses or doctors or CNAs, to see us as people, as humans, as equals. You know, you talk about equity in medicine, but it's just, if you don't see us as actual human beings like you, then it's never going to be any sort of equity, right? You wouldn't treat a dog, or some people do treat their dogs. You wouldn't treat a turtle the same way you do a human. But so that's our goal. Our goal is to take care of our own people as best we can, and to also establish relationships with others and sort of sway them to the fact that it's okay to treat us as equals. It doesn't mean you get any less. It doesn't mean that your life is diminished to treat other people as equals. And I think that's it for my slides, right? All right. Well, thank you guys for listening.
Thank you. Thank you. Now we have Nurse Nicole Kazarian, and I'm going to take off the share so that you can see her more clearly.
Thank you. Thank you, Jules. Thank you, Chief Holly and Dr. Brown. And I am just grateful to be part of this panel today. Like Chief Holly mentioned, our Indigenous people, I'm also part of the Hassan-Misko tribe. I'm a school nurse supervisor for the Woods Public Schools. Very excited about the direction the Woods Public Schools is taking in terms of equity and inclusion and diversity. But I'm here to share my oral story, my anecdote. Those stories are things that really speak to our hearts, and I'm grateful for this panel and the work that we're trying to establish and continue. And this is a very personal story that's near and dear to myself and my family, and needs to be told. And it centers on what we're talking about. Ironically, in today's paper, I don't know if many of you read, the Leominster Maternity Unit is looking to close. And so my story centers around maternal child health. And for those of you who don't know, we have the severe maternal morbidity rates. They've doubled in Massachusetts from 2011 to 2020, according to the DPH. And Black moms are more than twice as likely to die than our non-Hispanic white moms. Other statistics around infant rates, you know, the United States is, our infant mortality rates are far higher than third world countries, which is astounding. But according to the CDC 2020, Black and Indigenous babies are 8 to 10%, 8.4 and 10.4 out of 1,000. So about 2.5 times more likely for our Black and Indigenous babies to die in our country. So this brings me to my story. I have a niece, and her and her spouse, knowing these statistics, opted for alternative methods, or looking for alternative methods to have their first child, right? Given the picture that Chief Holly painted about experiences with poor treatment, or the concern for being a statistic. And so they were seeking a midwife and doula to help with the birth of their baby. So they did find a midwife who was Black, the only one in our state. And so about 1.5 years ago, my niece went into labor. And one of the other reasons why she wanted a home birth, or a birth not in the hospital, is, looking at having no medication, having a natural birth, having a safe birth, having a water birth. These are options that weren't available or are not available. And as she began her delivery, her baby was breech, and the midwife tried to deliver the baby at home. So the ambulance was called a little bit too late, and when my great nephew, Eternal, was birthed, he suffered a traumatic brain injury. He survived for 11 days. And that experience was very traumatic for our family, and highlights for us the need for us to do better. And the midwife, she wasn't a nurse midwife, but she was Black. And so even despite the goal, or the want to protect and to have a safe outcome, it was still a negative outcome. So we are looking into, the family and some community members are looking into regulations around midwifery in the state, and safer alternatives for Indigenous peoples of color, specifically around options for moms and babies. I know in the UMass system, there's talk about a doula program, which is exciting, but we just have to do a better job of being able to deliver care that is sensitive and gives options, so that these types of tragedies and our statistics improve. And one of those things that I appeal to you all on this panel who have the ability to affect change is in terms of formulating relationships, and coupling again on Chief Holly in terms of who we are as people, and establishing relationships that are trusting. That comes through being engaging, being understanding, and listening. There's a huge distrust in standardized medicine, and I think in our Western medicine, there's room for coupling of plant-based, holistic, natural remedies, and understanding, listening, and incorporating. I think that's what I think all of us on this panel need to think about, in terms of how we can do better and make a difference. So through this tragic event that affected and impacted our family, I hope that this is something you can think about when you're dealing with patients or in your research, or, I'm not sure who all is on the panel, but just appealing to you all here about how you as an individual can make a difference and can help us equalize and, to eliminate the barriers that racism in our country have provided for so long. So that's my story. And I thank you all for taking the time today.
Thank you so much. And thank you for all the panelists. We do have a couple of comments and questions. So one of the questions that came up that I think a lot of people have in their head is, can you share ways that we can support your community, can support the Hashtag-Misco band? And this can be any of the panelists.
Well, I mean, that's there's always financial support. There's always, which is even more, I guess the support we really need is this might sound kind of soapy and dopey, but can't you just be kind to each other and like spread that around? Because that's really what hurts us the most, is that people just don't treat us right, if you can't go into a store without being followed, it's just all over the place. And I don't know how to I don't know how to change it. I think that the pandemic made us so much worse. People are just like outrageously cruel to one another. So yeah, I guess that's, like I said, it sounds soapy and dopey, but spreading some kindness would be great. We do have an Indian fair coming up on Indigenous Peoples Day. I almost said Columbus Day, but I didn't. Yeah, and you can support legislation like getting rid of mascots, which is a current on the board legislative act right now in Massachusetts. It's and also changing the state flag. That's another thing. So those are two active campaigns right now in Massachusetts. Yeah.
And I think too, learning about plant-based alternatives and herbal medications, and being able to provide or to listen and to incorporate the use of both those types of therapies. In addition, there's a place for both, but learning and understanding and becoming practitioners of both to be able to give options for families.
Very nice.
Yeah.
And I noticed on the website there is the Nipmuc Corn Harvest weekend for 2023. Is there also one for Indigenous Peoples Day?
The corn harvest?
Yeah.
No, the corn harvest is before then.
I
So-
mean, is there another place
Oh,
where they
another activity? Yeah,
where they can see how to get to and how to celebrate Indigenous Peoples Day?
Oh, there's several Indigenous Peoples Day activities throughout the state, because several towns have declared the former Columbus Day as Indigenous Peoples Day. So like the town of Newton has something going on. Town of Grafton, that would be us. It's all over the place, but you'd have to Google that. So yeah.
Thank you
Yeah,
for
I think-
posting that, Heather.
Go ahead, Nicole.
No, I'm sorry, Heather, Lynn just
Oh,
posted
yeah.
the legislation bill and regarding midwifery care and birth options, legislation that the group is working on.
Yeah. But I mean, think about it though. People are people so afraid of giving birth in the hospital. I mean, doesn't that say something to you guys? That we're just afraid to give birth in a hospital? I mean, that right there should tell you everything you need to know about things that need to be changed if you're afraid to go to the hospital. So
I can
Yeah.
tell you something positive though. My niece and her spouse, and you know, this is with permission to share. So I do have a great nephew, Sacred, who was just recently born. And my niece had opted for a freestanding midwifery group in Florence to deliver her baby, but that was an hour and a half away. This time she went into labor. It was so far that she didn't make it to Florence and ended up delivering in the hospital. And thankfully it was actually it was a wonderful experience. Her the obstetrician was wonderful. The nurses were wonderful. They had a really, really great experience. And, you know, that's the kind of change that is needed for, you know, for people to trust and to utilize, you know, the healthcare options that are available. So there definitely was, you know, something positive, and we're very, very thrilled, but you know, that tragedy is just, you know, it didn't have to happen. And we're, you know, like we have to do better.
Yeah, it sounds like it speaks to two issues. One issue is improving care. The other issue is how do you make sure people know that you've actually taken efforts or made efforts to improve care? You know, I think that's really, really important.
I think that's where Chief Holly was saying is be kind, be nice. Every interaction matters. Body language, you know, your implicit bias, your unperceived bias, just the look, your tone, the attention, right? If there's a bunch of people and you're addressed somebody, but you know, it's all those little things that that make a difference and that help people feel comfortable and accepted and heard. You know, those are the things that that make those differences, that connection.
That's wonderful. So I think we have time for one more comment, and then we probably need to wrap it up. But someone asked, has there been any interest or ability to partner in some way with the Community Harvest Project also located in Grafton? Is there any sort of collaboration there?
no, we haven't. They're up the hill from us, I believe. I think that's what she's thinking of. But no, we haven't.
Okay. And lots of people appreciated your story, Nicole, and send their sympathies.
Thank you.
Excellent presentations. So there's lots of thank yous. That's wonderful. So before we close, what we wanted to do is say that this panel discussion is you know, it's part of Centering the Margin series because of the topic, but it's also a part of our ongoing collaboration with the Hassana-Misko Band, and part of that, our commitment with the Hassana-Misko Band is that we will do a series of panel discussions. This is the very first one. We have, at the very least, 3 more lining up. And so we would love it if you would keep your ear out. You know, it comes out in Up Next. And we'll be talking about Indigenous health and healing practices and sort of in more detail, the importance of representation in healthcare. And we'll also take some time at the end of the year to talk about our partnership and what all we've done, where we're going. One of the things that Chief Holly Cheryl said early on is that our partnership is such that we have to overcome so much that we really have to move at the speed of trust, and I thought that was a really beautiful statement. And so look out in the future. We'll have 3 more panel discussions throughout this academic year. And I want to take time to thank Nicole Nurse Kazarian for your personal story and really putting your heart out there and talking about the realities of life right now. And of course, Chief Holly, as always, we really appreciate you talking about the history, but also what's happening right now. What are we doing right now? And so that's we really appreciate that. And Dr. Brown, of course, setting the stage of racism in medicine, racism in healthcare. I think it's really important, as we're going through and changing our curriculum. That's one of the things that we've started talking about in all of our schools. So thank you all very much. We really appreciate it. Dr. Duncan, I don't know if you wanted to say anything at the very end or not, but if not, we'll wrap it up here.
Just wanted to express my true gratitude and thanks to you all, everyone on the panel, everyone that attended the session. I know I learned a lot. It was a wonderful sharing of stories and experiences and research. So really appreciate your time and talents today, and thank you.
Thank you all.
Thank you for having us.
Thank you all.
Thank you.
Thank you. Great presentation.
Thank you. I'd like to I think we probably should turn off the recording. So we'll stop the recording.